Kia ora. Welcome to day 4 of the COVID-19 Masterclass. I'm Jackie Haddingham, Manager of the Otago Global Health Institute, OGHI for short. Today's webinar will run for 1 hour. We'll finish at around 1 p.m. New Zealand time. Just a reminder that our webinars are being recorded and will be available on the OGHI website later. We're also live streaming on the OGHI Facebook page. During the webinars, each speaker will do their presentation, and you can ask questions at any time through the Q&A function at the bottom of your screen. After the presentation, I'll read the questions aloud for the speaker to reply. We have quite a tight schedule for our webinars, so if we're not able to get to all the questions, we'll send them to the speakers in writing and post the answers up on the OGHI website page. Our first speaker today is Associate Professor Tony Walls, who is a pediatric specialist, an infectious disease specialist in the Department of Pediatrics at the University of Otago in Christchurch. Tony is going to discuss children and COVID-19. Tony.
Thanks for the introduction, Jackie, and welcome and good afternoon to everyone who's joined us. Thank you for tuning in. So as Jackie mentioned, I'm an infectious diseases specialist and paediatrician who works here in Christchurch. I'm going to be talking about COVID-19 and children in particular. And I think probably there's been a few misunderstandings or misinformation about the role of COVID-19 in children from early on in this pandemic. So hopefully we'll touch on a few of those. And I'll also be touching on looking at it from a child health focus on this pandemic and how we've been managing it. Just before I get started, I'd like to acknowledge some of the help I've had with some of the slides in this presentation. Mavis Duncanson at the New Zealand Paediatric Surveillance Units provided me with some data along the way, and also I've had some help with some of the research that I'm going to be presenting, which I'll acknowledge as we go along. So if there was a take-home message from this talk, it's that children are different. This is one of the reasons why some of us really enjoy working in paediatrics. And down the years, down the decades, paediatricians have always been teaching their students that children are not just little adults. And I think COVID-19 has really highlighted this nicely. This is kind of the general picture I think many people have of children in relation to infectious diseases and virus infections in particular. We think of them as little virus machines that spread disease throughout their kindergartens, their preschools, and they bring those home and persistently snotty and passing around viruses. And of course, for many infections, that's exactly true. For influenza is the prime example, where children are the main vectors of spread within communities often. But the big point I want to make today is that for COVID-19, things are very different. And we can't use that same approach to children and our same understanding of how things, how diseases, particularly viral infections, are spread amongst children just doesn't apply. So we need a different look at it, we need a different approach. And of course, much of our pandemic planning done prior to this pandemic was with influenza in mind. So many of the steps that we've taken along the way may not have been entirely appropriate given the different paradigm we have with COVID-19 in children. So I'll go through a little bit of that shortly. So right at the start of this pandemic, I watched this webinar it was broadcast on the Australasian Society of through the Australasian Society of Infectious Diseases, and it had some really interesting comments. So Dr. Elwood was the co-leader of the joint mission from the World Health Organization into China. He's a gentleman he's Canadian. I understand he's worked for many decades in infectious diseases with the World Health Organization and been involved with many epidemics such as Ebola and SARS, so a vastly experienced clinician and epidemiologist. And it was quite enlightening right at the beginning to listen to his talk. And I guess the main thing that struck me was firstly that this is someone who had boots on the ground. The joint mission had been to China. They'd been talking to people who had been experiencing an epidemic and a large outbreak, and so they were seeing it for themselves. And these are the main messages that came through from that talk. Firstly, the very first thing was this is not influenza. Everything that was happening on the ground was very different from an influenza outbreak. And equally, it was significantly different from the previous experience that we'd had with SARS. And in relation to children, their main message was that things were different again. So that the severity of disease that children were experiencing, the way it was transmitted to children and where they were obtaining it was very different from things that had happened in previous epidemics. So what I'm going to talk about today, I'm going to talk a little bit about the epidemiology of COVID-19 in children. We're going to take a look at this concept of schools and are they a safe place for children to be. I'm going to touch on a little bit on severe disease. And then I'm going to talk about from a sort of more from a parent's perspective, what parents are thinking about COVID-19. So if we just start with the New Zealand epidemiology, and this is just slightly different from what you may have heard earlier in the week. So there haven't been any hospital admissions for children in New Zealand with confirmed COVID-19 infection. Now, last night I had an email catching me up that there has actually been one child under the age of 15 who was admitted to hospital. They tested negative for COVID-19, but were listed as a probable case because they were in contact with some proven cases. But in general, there haven't been any children. So paediatricians around the country have been sitting waiting for the coming tsunami of severe infections at alert and with infection protection controls stuff in place, and children's wards up and down the country have generally been incredibly quiet, particularly quiet for this time of year when we're usually expecting a surge of disease. And if you look at the actual numbers, you can see here that in children under 10 years of age across New Zealand, these are up-to-date figures, there's only been 10 confirmed cases and another 27 which are listed as probable cases. And then in the older age group up to 15 years of age, 29 confirmed cases and 18 probable cases. So very low numbers, and as you can see on the right, we've done exceptionally well in New Zealand in terms of restricting the spread of COVID-19, as you've heard in previous talks. So what about what's happening in the rest of the world? We could have taken examples from anywhere really in any of the major countries because there's lots of data now available, but I've chosen to go with information from the United States where clearly now there's a lot of transmission and a lot of data available. So this was again pretty early on in the epidemic that this was published, and it's covering data from February and the early part of March in the United States, looking at the different age groups of infections and the outcomes of those in terms of hospitalisation. If you look at the age groups along the bottom, I guess the first thing to notice is that they're not in equal brackets. So the ones on the right are in 10-year increments, the ones on the left are in 20 or even more increments, so it doesn't quite fit. This is number of hospitalisations on the vertical axis and the age groups along the bottom. Well, the striking thing right from the start of this epidemic was that children were just not affected very often. And you can see here, even up to age 20, the 20th birthday, there was very few children being admitted to hospital in the United States, and obviously no deaths and no ICU admissions at that time. Now, if we look again, similar sort of time frame, a little bit later perhaps, and this time this is confirmed cases who have tested positive for COVID-19. You can see the older you are, the population, the rate of disease in the population, rate of positivity is much greater. But in those children, even up to their 18th birthday, the rates of disease are incredibly low. Now, I've deliberately chosen ones from early in the epidemic in the US, but if you look at ones from later, the pattern seems to be very similar. Now, one of the things that people have said is that maybe we're just not testing children. So I thought I would include the next slide just to illustrate that there are some places where there has been a lot of testing and they're still found that very few cases are testing positive. So this is from Philadelphia, the Children's Hospital Network in Philadelphia. and it covers the the time scale from very early on in the epidemic to recently. And if you see on the vertical axis, you can see the number of daily tests that were done and the percentage that are positive. And the dark bars are showing the positive test. The lighter bars are the ones that have tested negative. And this is a population not just from a hospital network, so inpatients, but also including drive-through clinics where people are getting tested. So presumably most of the people coming through drive-through clinics and through ED, the emergency department, were symptomatic, or at least and worried that they might have COVID. And you can see the total percentage of positive cases, positive tests is very low. And in fact, this is taking children children, young adults, all the way up to 21. But if you take the group of children who are under 5, it's even lower than that. So the percentage was under 4% were positive. So the younger they are, the less likely they are to be positive. But overall, a low rate of positivity considering the amount of transmission that was going on in the US at the time. So this next slide is from China, and this is one of the first case reports that came out of what was happening to children who were admitted to hospital. And they tested over 2,000 children at the Wuhan Children's Hospital, and 172 of those were positive. And this is a letter that was describing the outcomes and characteristics of those children who were tested positive. You can see, firstly, that a large proportion of children who were in hospital had either asymptomatic infection or a mild, what's described as upper respiratory tract infection. 65% of the children had pneumonia as part of their presentation. But the interesting part about that is it was very mild if it was described as pneumonia. So they may have had X-ray changes, but they were only mildly affected. Only 4 children had oxygen saturations below a level that we would give supplemental oxygen for, which is remarkable, really. And only 3 required admission to the pediatric intensive care unit. And this is in the winter months in a large children's hospital, and normally there would be quite a few children being admitted with respiratory disease at that time. So the conclusion from all of this was, again, what we said at the start, that if children are getting infection, they're generally milder, and there's very few cases where they have severe disease. But the thing that really struck me about this data, the thing that I found most interesting, was the exposure information. So if we look just down at here, you can see that more than 90% of children who were admitted to hospital were thought to have acquired it within a family cluster. So most likely to have acquired it from an adult. So this is not a situation where you've got children passing it on to other children in the community. And almost all of the cases are getting it presumably from an adult in the household. And if you look at data from the US at the similar sort of time, remarkably similar numbers. Over 90% of children where it was documented where they got the infection from, it had come from in the family, it had come from a family cluster rather than out in the community. And again, this again highlights something that's very different from what you might see with influenza disease. So what does this mean for school children in New Zealand? Because that's the kind of question that most parents have been asking along the way. So I'm just going to look at what's happened, what the data we have in New Zealand, and a key study from New South Wales, which is, I think, helpful in this area. So this is the New Zealand data. Firstly, there's been no school clusters in preschools or primary schools. And when the plan was to send children back to school into preschool, there was clearly a lot of concern and worry from staff in those areas that they might be at risk because of children. If you look at the cluster that had happened, the first one was probably a misnomer calling these clusters, because either they haven't happened in schools or there haven't been many of them. So there was one child who was at school for a day, symptomatic, at Logan Park High School. They tested a large number of children in that school who were potentially in contact with that child, and there was no transmission. Then there's what gets referred to as the Marist College cluster. And again, this is a bit of a misnomer. There was about 92 cases overall in that cluster, but only 36 of those were children. And these are all high school age children. The index cases were both teachers, and it's thought that much of the transmission occurred either at a social event that was organised and associated with a school but not at school, or within the families when people who had acquired disease had gone home. There was only one suggestion of a case where a child had given it to another child in a school setting. There had been some other cases that it suggested that children had given it to other children in a household setting. So although it's called a school cluster, and that was the impression that was out there in the media, I guess, majority of cases in that cluster were not in fact children, they were adults, and the vast majority had not acquired it at the school. So this is a key study that was coming out in April from the National Centre of Immunisation Research and Surveillance in Sydney, in New South Wales. And this is a detailed study looking at transmission within school. So there were 18 individuals who were identified testing positive with COVID-19 from 15 different schools. And what the public health units did some close contact investigations of over 850 close contacts of these individuals. So 9 of those individuals were adults who work in the school, 9 of those individuals were children, and no adult contacted disease from a child. And that was actually really important because at the time, I understand in Australia and ongoing in places like Victoria, there were concerns from unions and people representing staff that it was dangerous for them to be at school in the pandemic. But in fact, in New South Wales, it seemed that adults were safe from the children at that point. I'm just going to look at the primary school cases. And this is a diagram that sort of explains what was happening. So you can see in the primary school, there was only one case that was a secondary case, and that had come from a staff member in that school who was COVID positive. In the other schools, you can see most of the positive cases were adults or staff members that worked in the school, and there's only one that was a child. And there was no child-to-child transmission within the school. There was only one other case they identified in a secondary school, and this had actually been someone who may have developed disease with connection at the school, but in primary schools there was no transmission. So overall, out of well over 800 close contacts of children who had been in schools known to be COVID positive at the time, the transmission rate was incredibly low. So that's actually really reassuring. So, and around that time, Professor Phil Hill and I put out a statement just as schools were going to be looking towards opening up in New Zealand, saying that we thought the schools were as safe as they'd ever been. It was kind of coincidental. We hadn't seen that data when we put the statement together, and our discussion was really based on information that was already out there, but it worked well. So I just want to talk briefly about the things that are scaring parents and others. And one of those is this severe disease that has been presented across the globe. Sometimes talked about as Kawasaki-like disease, although there are significant differences from Kawasaki disease. This is a systemic inflammatory syndrome, for want of a better term, which may be related to COVID-19. People aren't really sure. The key thing is that it's rare, and in a recent case report from the UK, they only were able to identify 58 possible cases, and that's out of a group or a population of something like 11 million children across the UK. And many of those cases actually would fit diagnostic criteria for Kawasaki disease. So first thing is it's very rare. It is a severe phenomenon in terms of the individual children can be fairly sick. But I guess the main issue and problem with this was that a warning was put out over Twitter right up front without going through any scientific analysis. And so it's spread around the globe as a scary thing that was happening to children, and people are seeing it and think it's an incredibly common phenomenon. Obviously, with no hospitalised cases in New Zealand, we haven't seen any of this. But I think it's loomed large in the media and loomed large in parents' thoughts. So just prior to the time when schools were about to start up, we put together a survey because we were concerned that parents were really worried about sending their children back to school. This was a survey sent out via Facebook. We got over 1,100 responses, and thank you to anyone who might be watching this webcast who participated in that survey. And we asked parents of school-aged children a number of questions around how scared they were of COVID for their children and other things that have been going on with their children. But I'll just hit on the key things here. So nearly 80% thought that if we were in a situation, which we weren't at the time, but if there was widespread community transmission, 80% thought that it's likely or very likely that their child would catch COVID if they were at school. More realistic to what was happening, because this is when there was very few cases in New Zealand and schools were about to be open, but nearly 15% were extremely or very worried that even with no community transmission, their child was going to catch COVID if they sent them back to school. More than 50% in total were somewhat worried that their child would catch COVID if they were at school. So from my point of view, it seemed like there was a big disconnect between the public health messaging that was saying it was all okay, the science that was saying that actually transmission is unlikely, and the level of worry amongst parents along the way. The other thing I should say is that the other thing that came out of the survey is that something like 80% of parents would be prepared to vaccinate their child. If there was a brand new vaccine around, they'd be prepared to vaccinate their child against COVID. And I think that really does express the level of worry that was out there in the community. So I guess the big question is, what harms have we done through our infection control measures along the way when there's very little risk of childhood disease? There's certainly been a lot fewer GP presentations, hospital presentations, which I'll show you some data on in a minute. We had an immunisation coverage which is generally really, really good in New Zealand, but in the last couple of years it's just been declining a little bit, and having children in lockdown certainly hasn't helped that, and there'll be those that have been avoiding it. Clearly there's been a lot of missed school that's going to have implications for many students, and there's also been mental health challenges which I think are largely unrecognised, and I'll cover that a little in a minute. But I think the main thing is that any impact that's been had on child health all across this has really been likely to be the greatest in disadvantaged communities. They're the ones that are least likely to access services normally. They're the ones who are least likely to have, or more likely to have, their children missing school. So I think it's going to be disproportionately effective across the schools. Here's some data from Christchurch ED, and thank you to Laura Joyce for helping with this. So this is hospital admissions for children under, emergency department presentations for children under 15 years of age. The rolling average is between the red lines over a 10-year period and the predicted off to the right-hand side of the graph. And the baseline in the blue, number of attendances at ED along the way. You can see just as things were locked down, dropped off dramatically and remained very low right through level 3, and even through most of level 2, actually, they remained really well. Now, much of this can be explained by less transmission of infections in the community, lots of other different presentations, but actually there are some more worrying things in amongst these statistics. Normally in the month before lockdown, there were 15 presentations that were coded for mental health diagnosis or suicidal ideation in young people. And in the lockdown time, there was 0. And normally we would have a lot more presentations there. So it does make me worry that we've been missing a whole lot of presentations of children that would normally be there. Finally, just a teaser really. Some of you may have heard this on the Sunday morning program, where there was some relationship, some data suggesting an association between male pattern baldness and androgens, and the extent to which people are affected by COVID, backed up by some data from Italy, where men were much more likely to end up in ICU. In Spain, where men admitted were 80% of them had male pattern baldness. It's kind of intriguing. I don't know what to make of it. It's worth having a listen to. And I kind of wonder whether that may be one thing that may explain partly why children aren't getting this disease. It's a big unresolved question as to why children don't get this disease as much. I don't have the answers, but that's an interesting thing that I thought I'd just chuck in. So just to summarise, the big message, take-home message, is this is not influenza, and in particular in children. The severity of disease that children get and transmission dynamics are very, very different in children. And I think the way we structure public health policy needs to be cognizant of that, so that we're not restricting or limiting children's access to schooling, access to healthcare. And just finally, children do spread disease. They do have some disgusting habits sometimes, of which they're likely to pick things up, but certainly not with COVID. And if those of you who are looking for that quote that I had at the start, that's from Oscar Wilde. Thank you very much for your time. I'm happy to answer any questions, Jackie.
Thank you, Tony. Yes, we have quite a few questions. I'll go through them in the order that they were received in. Firstly, has there been any consideration given to the fact that high percentages of children were in lockdown and therefore more likely to contract COVID from family? Also, fewer respiratory hospitalizations due to less pollution in cities?
So certainly that data I showed you from China, it was the New Year's holiday for most of that, and so children would not have been in schools at the time. So there's no question that's likely to have contributed. The flip side of that is probably places like Singapore, where early on in the epidemic, when they were controlling disease, schools were open. They took a deliberate move to, while they were restricting movements of people and closing the borders, they kept the schools open. And I haven't seen any specific data out of Singapore, but I have had contact with Dale Fisher, who is one of the leading public health people over there. And he said that anecdotally, they just haven't had any clusters that have been based around preschools or schools. So I think it actually is a real phenomenon that children aren't picking up even when there are schooling. Other data that might back that up would be places where they've actively gone looking, like in Iceland, where they did whole population surveys of asymptomatic people. And when they tested a raft of children under the age of 10, not one case was positive for COVID-19. So there is a fair bit of data suggesting that what we're seeing is a real phenomenon. I'm not really able to comment on pollution in cities, really. It's not my area of expertise, so we might move on.
Thank you. What is your view on COVID in children being an asymptomatic gastric infection? Are there any studies looking at detecting SARS-CoV-2 in stool samples in children?
So there are case reports of it being detected in children. Many of you may remember with SARS, the original disease, there was considerable concern about transmission in stools. The only studies I've really seen have been around detection, where people have gone looking in stool in infants and children who have been hospitalised, and it's been confirmed that a small number of them do have it detectable. It's not in the list of symptoms in some of these larger case series. It's not a prominent feature, and I suspect that it's probably unlikely to be a significant cause of transmission either in hospitals or outside of hospitals.
There seems to be low numbers in children, but the young adult group has high numbers of positives. Is there an age where this swaps over, and any idea of the relevance of that?
I don't think anyone's got a clear cut-off age for that, but it's exactly right in our data in New Zealand and other countries that you're more likely to get it in if you're in that sort of 15 to 20 age bracket. And I'm not sure any of us have an explanation for that other than the type of activities that those older children are likely to be involved in socially. And that's really speculation, to be honest. I guess most people still, when they've categorised things, have shown sort of up to that age 20, even though there's more disease or infections being detected in the older group of that, there's still very few hospitalisations at that time. So I don't think any of us are really sure.
Okay, we have time for one last question. What do you make of the COVID-19 situation in the US, specifically with regard to reopening of schools?
I think the reopening of schools is a really challenging thing. It was quite an easy decision in New Zealand. And it's a difficult one. I think that from a purely child health perspective, i.e. what's the risk of a child getting COVID disease even in a high incidence country, I think that the risk is still pretty low of them obtaining it in a school from another child. And so you might argue that the downside of having closed schools in terms of child health might be worse than keeping them all at home. We know that children aren't the drivers in communities, so that's an argument for keeping schools open. And we know that it's possible to contain the disease in a population like Singapore with schools open. I guess the US has such widespread transmission at the moment, it's challenging. The argument for closing schools is, in my view, a population level argument whereby if you're going to have lockdown, it's pretty hard to have a really strict lockdown while you're sending your children to school. And so from a public health messaging point of view, closing the schools is advantageous. But if you're looking at it from a child health point of view, I think the arguments for closing schools are not that good. And in fact, with the original SARS epidemic, there was a paper put out estimating the impact of closing schools at that time, and it was felt that the actual impact on reduction in community transmission by closing schools was absolutely minimal.
Thank you, Tony. Unfortunately, that's all the questions we have time for.